It's a very dry subject, this, isn't it? Risk stratification. I could just stand here listing tables and various guidelines. But what I want to do today is actually place risk stratification into relevance for our next 20 years of healthcare. And that relevance is the fact that we've got an ever-increasing elderly population that will demand medical resources. I'm going to present a lot of data from the last 5 years which has been developed by John Carlisle at Torbay. And I'd like to acknowledge him for that. He's been very generous and he's very pleased this data is being presented today. So let's start by asking, why do we want to quantify perioperative risk? First of all, obviously we want to inform patients of the risk, because some people have no idea that they're coming for high-risk surgery. Then we can actually optimise those people at risk. We can resource allocate, so we can give them intensive care beds to reduce complications. And there's an increasing relevance with increasing age that they've got more comorbidity, so it's more important to assess risk. And also, there's an expectation which changes with age. Yours and my expectation for major surgery will be going back to playing tennis and football. Whereas if for an elderly person, it's going back to caring for themselves. So if they actually end up getting through surgery but going to a home and having 24/7 care, that for them is a disaster and not a success. You ask, well, what is the state of play in Europe at the moment? And I'm just representing this. This is from The Lancet 2 weeks ago. It's the USOS paper, the European Society of Perioperative Outcomes group, and basically it's data over 7 days where it was collected consecutively in about 500 hospitals. Major surgery, all comers, and the primary endpoint was mortality in the first 60 days. Then there was a secondary outcome measure of duration of hospital stay and admission to critical care. And the results have been quite shocking. We're expecting a perioperative outcome rate, a death rate of about 1.6 to 2%, but it's actually 4%, so it's over twice what we expected. And this is a large population group, as you can see, 46,000 patients, so you can't hide from this. And the really surprising thing is the use of critical care. Only 8% of patients went to intensive care, and almost 3/4 of patients died without even seeing an intensive care unit. These are the national data. One thing I would like to point out is if you look at most of the countries at the top are the ones that have adopted enhanced recovery. Just to start with traditional scoring systems, you're all familiar with the ASA status, the American Society of Anesthesiologists. It's 1 to 5, and it just gives you a rough guide of what that patient's pre-existing conditions were. It's not very useful, though, for risk index. Then we've actually got morbidity and mortality risk indexes, and there's an awful lot of work done on cardiovascular risk. For some reason, people are absolutely fascinated with 30-day cardiac events. If we look at morbidity and mortality risk first, POSSUM has already been touched on, because it's in the ERAS database. And it's a physiological severity scoring. And already we can see certain key issues coming in. Age, cardiorespiratory performance, which pumps oxygen around, and then whether the other parts of the body are disturbed, all the other physiological processes. And you can actually get a risk, morbidity and mortality, and look at how your patients do. It has been modified, first published in 91, then modified in 96 by Mark Whiteley in the Portsmouth group. It's called POSSUM, so you might have heard of that as well. It's still used widely today. Intensive care, which I do a lot of, we use Apache 2, and this is a lot more complicated. It uses physiological parameters. Again, if you have a look, it's all to do with organ dysfunction. Age, again, important, and then how things are being affected. However, it also takes into account pre-existing diseases, and these are the major ones. Again, cardiorespiratory, anything that's affecting oxygen delivery. Liver and renal means you've got metabolic issues. And then if you've got anything which immunocompromises you, obviously you won't fight infection, so you're more likely to get infection and you won't heal properly. And if you add in another couple of factors, which is the cause of admission, so if they come with a chest infection, sepsis, or a cardiac problem, and also whether emergency admission, you get this population database, which has now been validated for tens of thousands of patients where if you increase your Apache score along here, you increase your predicted mortality, up like this. And this is why when the F1s come to me and say, oh yes, we've got a 90-year-old who's got a PO2 of 6, ischemic heart disease, acute renal failure, but they're otherwise okay, and you do your Apache score and they're up here, you realise why I know that that patient's not going to do very well. But Apache is complicated, and it's when patients are actually sick. And of course, in elective surgery, we're dealing with patients who aren't quite sick yet, but have comorbid problems. So cardiac risk is traditionally focused on 30-day risk, and we've had the Goldman and Dexke indexes and the Lees Modified Risk Index. I'm going to put Goldman up again because he does deserve credit, because this is 1977, and he's shown that if you've got heart failure or ischemic heart disease or other things like emergency surgery, if you add up the scoring, it increases both complication rate and incidence of death. But those numbers aren't relevant today. But what is relevant today is the Lees Index, and Lees Group in 1999 modified this, and they came up with these 6 factors, all of which independently increase your risk of major cardiac complications. And the reason I put this is still a mainstay of actually perioperative risk prediction. I use it in my daily practice. And the key thing is any one of these scores 1 point, but the points aren't additive. You can see as soon as you get to 2 points, your risk goes up quite considerably. So it doesn't take a lot, really, because you can score 2 points just by having a history of peripheral vascular disease or cerebral vascular disease coming from major surgery. And yet suddenly your major complication rate's gone up. This is for cardiac complications, not death, so don't confuse that with the other one. So John Carlisle's done an amazing bit of work with Mike Swart over the last 5 or 6 years. He's taken an actuarial approach to risk, and he's used population-based data, which counts of millions of patients in the UK, rather than just looking at a group of 10,000 patients and how did they do. And he's also included the key risk indices, which are basically those Lees index I've just put up there. And what he's trying to do is, if a patient comes in front of you, instead of just being able to say, oh, you've got a 20 to 40% chance of getting a problem, and you've got a 2 to 8% chance of dying, he's actually trying to give people an exact risk of what are they going to do, what's going to happen to them if they don't have surgery, and what is the risk of dying if they do have surgery. So it's individualised. And the reason this is important is we've got an increasing population age. Again, this is all UK data. But it's quite frightening that in the next 20 years, our population over 80 is going to double. But this is the killer slide, because when you look at our population overall in the UK, it's going to go up by 10%. But when you look at the actual users of healthcare, which is below this line, you can see it's almost going to go up by 40%. So it's going to bankrupt the healthcare system. Now, you might say I'm being ageist. Well, I'm not really, am I really? Because if you are elderly, you're closer to dying. So no one can dispute that fact. And the problem is elderly have more comorbidities, reduced cardiac function, and therefore at higher risk. But as I said, they also have a very different expectation. They might have a Duke's carcinoma of the colon, but they could have ischemic heart disease, had 5 stents which keep blocking, and they might only have 3 months to live. In which case, are they going to die from the disease or from something else? These are important questions we need to ask. And also, if they have surgery, what's the chance of getting back to their preoperative status? Because for them, they'd rather live 2 years at home than actually have an operation, have a high chance of either dying or actually not getting back to their preoperative status. So what John Carlisle's done, he's used these risk estimates on larger populations, and basically said that preoperative risk can be calculated and post-operative risk estimated for anyone. And basically gives a patient a good or a bad outcome before or after surgery, with or without surgery, and therefore they're informed and they can decide what to do. And it also helps us adjust resources. So for interest, I'm actually going to run through the work for you and what he's done. The 2 key things are the patient's physiological status and then what they're going to have done to them. That's common sense, really. There's 4 survival predictors for all of us in this room. Age, whether you're male or female, what your socio-economic status is, and your fitness. And then there's other key areas, which are those Lees criteria, which affect things as well. But let's talk about age and sex first of all. The risk of death doubles every 7 years you live. So a woman who's 58 has a 1 in 2,500 risk of dying, and when she gets to 65, it's 1 in 1,250. But a man's risk of dying is 1.7 times more than that of a woman. Socioeconomic background has a major effect on your risk of dying. If you've impoverished, you stand 1.5 times the chance of dying every year. Or if you're wealthy, 0.7 times the risk. It reduces your risk. Then the fourth thing was fitness, and we measure that in METs. And this is useful for you to know anyway, because we use it in preoperative testing. A MET is a basal metabolic rate, what our body does. And MET's about 0.16 times the age for men and 0.13 for women. And there's an expected range up there. But the things you need to know about is climbing a set of stairs is 4 METs. Strenuous exercise is about 10 METs. The inability to perform 4 METs has been evidence-based to give you a poor outcome after surgery. Whereas good functional capacity, even if you have a bit of angina or COPD, surprisingly you have a good outcome. So functional capacity is more important than just ticking the boxes on what that patient has as coexisting disease. And we can measure METs both indirectly using shuttle tests and walk tests. I'm not going to touch on that because Franco's going to give a fabulous talk shortly on that. I'm going to talk more about the direct way, a scientific way, which is cardiopulmonary exercise testing. But just so you realise, the risk of dying is more in unfit people. So this is all going to get you going down the gym tonight, I'm sure. And you can actually multiply the risk by 1.19 for every MET you are short of your expected peak power for your age. Likewise, if you're fit, you can decrease it by 0.84, which probably means that Bradley Wiggins is never going to die. So what is CPET, cardiopulmonary exercise testing? Some people refer to it as CPEX, just so you know it's the same thing. It's a dynamic, non-invasive test of aerobic capacity during exercise, and it basically stresses the body similar to what you get with an increased demand of oxygen during surgical insult. So it's basically stressing the patient, seeing how they do before you do surgery. The 4 main CPET variables which have been shown to predict outcome are peak VO2, which is basically how much oxygen you get going around your body, which is common sense, the anaerobic threshold, which I'll talk about in a second, and then ventilatory equivalents of CO2 and O2. And those are very useful because it helps us determine whether someone's short of breath either due to a heart pump problem or whether it's a lung problem, because sometimes that's not clear. And all we do is we chuck someone on the bike, and it's nearly always a bike because they can't do a running mill very well. And we have a continuous measurement of our sealed mask. We calibrate the gases, and you measure oxygen in, CO2 out, and concentration. You can work out absolutely loads and loads of variables. You're also effectively doing an exercise stress test with an ECG, like a Bruce protocol, at the same time, so you can look for ischemia. So it gives an enormous amount of information. And what we're looking for is basically when your CO2 starts deviating from the line. And this is called the anaerobic threshold, and it's the threshold above which aerobic respiration alone cannot meet metabolic demand. And the easy way to look at it is lactate's produced from muscles when you're not pumping enough oxygen around. So lactate levels increase in the blood. I mean, that's why we all get achy and tired, isn't it? And then the acid load is buffered by carbonate, and this increases CO2 production, so that goes into the blood, and that's why you get that upstroke. And it's quite interesting, when Alder first did this work in 2000 in Australia, they found quite a range of anaerobic thresholds. This was in about 1,600 patients, and this is anaerobic threshold there, so people really do vary in their fitness. He then used it in colorectal surgery, this is over 10 years ago now, and looked at different ATs, an anaerobic threshold of 11 with no other problems, and these patients went to the ward and none of them had any mortality. He then looked at a group over 11 but had myocardial ischemia who went to HDU, had mild mortality, and then a group less than 11 who all went to ITU but they still 5% death rate. And that's why we've come about these figures of an AT of 11 or less being an increased risk from major surgery, but it's only validated in colorectal. And there's been fabulous work from Newcastle, Chris Snowden, where they've done further work with CPEX and done regression analysis and looked at the incidence and basically the cut-off point for post-operative complications affecting length of stay, and that's a fabulous piece of work. So that's a good number to have in your mind as well. But also, if you do thoracic surgery, VO2 max is important. And this is another bit of profound research from John and Mike down in Torbay. They did a lot of aneurysm testing. This is how they got their databases going. But they showed that if you CPEX someone and you still got them through surgery, if they started off with a poor CPEX, and this here, they had 130 patients, and then basically they all got through surgery. But what was fascinating is if you have a low anaerobic threshold, you die young anyway. So this anaerobic threshold is effectively picking up people who have not got longevity in their genes. Now let's get back to the risk calculation. So we've already done up to now those things. These are the 5 points I told you come back from these criteria. And for every one of these, you can increase your risk of dying every year by 1.5 times. So myocardial infarction, heart failure, stroke, peripheral vascular disease, and if your creatinine is greater than 150. So to summarise all that work they've done, for a patient individualised, you can look at their age, whether male or female, their socioeconomic status, their fitness in METs, which is CPEX or walk test, and those 5 variables there. So next we need to look at operative risk, and this is Boersma's risk index, still used really. I think it's probably going to be rejigged because with laparoscopic surgery and things, some of these are moving around. And what was intermediate risk is becoming slightly higher. So I think we'll see this group here being actually split into a sort of 1 to 2% and a 4 to 5%. So we end up with an operative risk whereby if you look at your preoperative risk, which is your risk of dying even before you go for surgery, and times it by a factor reflecting the severity of operation, you can work out your risk of dying from the operation. But of course there are other variables, the surgeon, the anaesthetist, and whether you're doing enhanced recovery and how good your preoperative care is. So that sort of completes the bit on risk stratification. Again, I could spend all day on medical optimisation, especially cardiovascularly, so I'm just going to briefly go through things that people keep asking and which have just been published in the latest ERAS guidelines. The AHA guidelines were published in 2007 and updated since then. And these basically look at active cardiac conditions which the patient should undergo evaluation and treatment for non-cardiac surgery. I'm afraid I'm just going to refer you to that reference because to go through all this, we have whole days of this on preoperative care dealing with this, so it's just to basically give you knowledge that that document exists. But there are a couple of useful things to come out of it. Beta blockers got a bad name because of the work done by Dan Polderman and the publication errors and things. And then you had the POISE study where people were effectively overdosed with metoprolol. But there is no doubt there is a group of people that beta blockers help. It's in those that have got ischemic heart disease or no myocardial ischemia, according to preoperative stress testing, patients in high-risk surgery, and then it's important to continue them through the perioperative period. But it's important to look at them as beta blockers as rate limiters, not bradycardic agents, because we also know that oxygen delivery and heart rate is cardiac output is heart rate times stroke volume. And also statins people always ask us about. Statins for cardiac risk, you should really start in high-risk cardiovascular individuals 30 days before, and that's class 1B evidence, and continue it perioperatively. Haemoglobin, there's loads of data, but basically it still remains if you're fit, 8 grams per decilitre or 80 grams per litre, whatever units you use is fine. People with comorbidities, particularly cardiopulmonary disease, you want it a little bit higher. But there is this important thing of risk-benefit of transfusion, but you can give everyone an oral supplementation. Smoking, there's good work by Sorensen in 2003 to show an increased risk of pulmonary complications. I think no one will argue we see smokers cough, cough, cough. But on the other hand, we see the benefits of the fact they have to walk the length of the corridors in order to go to the smoking room. So there is incentivisation for them to get mobilised. And really want to leave them off their cigarettes for 4 weeks. Alcohol, I don't know what the definition of alcohol abuser, but I think the whole of the consensus committee group probably fulfilled the criteria for this. They're at risk of bleeding, wound infection and cardiopulmonary complications. Again, 4 weeks abstinence is probably of benefit, although the evidence is not at such a high level. But do not get confused with alcoholics with established cirrhosis, or portal hypertension because they're extremely high risk of any elective surgery for all these reasons here: bleeding, hepatic decompensation, renal failure and delirium. So to summarise, the pre-optimisation, you can't change your age, sex or socioeconomic background, but you can change your fitness, you can optimise pre-existing diseases, and you can put people on beta blockers and statins if they score cardiovascular disease risk, and you can stop smoking and reduce alcohol intake. And to summarise John Carlisle's work, post-operative risk of death and morbidity is most effectively prevented by reducing the pre-operative risk of death and morbidity. Leads very nicely on to Franca Carli's talk. Post-operative risk is best estimated by precisely calculating the pre-operative risk and then multiplying by a factor reflecting the severity of the operation. And pre-operative mortality is most accurately assessed by incorporating a measure of fitness, so that's either the shuttle walk or doing a CPET test. And my conclusion, in the face of our current healthcare economic climate with increasing elderly population, with increasing comorbidities who are going to demand more and more from our medical services, is we really do need to improve our risk stratification for surgery to ensure we do the right thing for each person. And that might not always mean operating and doing surgery. We can then also identify those risk individuals and reduce their risk of surgery to optimise their outcome. But we really do need to, in studies, look more at just mortality and more at quality of life as a key indicator for surgical outcome. Because like I say, it might look like on paper success if we get a 90-year-old through surgery, but if that means they've gone from an independent lifestyle to 24-hour care in a home, that for them is not a successful outcome. Good, thank you very much.